Welcome to Coastal Front. Join us each week as we sit down with the movers and shakers of Vancouver to discuss stories of business, politics, accomplishment, and failure. Our aim is to keep you dialed into what matters most in our city. Now, here's your host, Andrew Johns.
All right, well, here we are with Mark Tyndall. You're the professor of medicine at UBC School of Population and Public Health.
That's right.
I've got that right?
That's right, yeah.
Great. Well, Mark, I'm really excited to have you on the show today.
Thanks.
We are going to talk about two main themes. One is going to be about drug policy in British Columbia as a topic that you're well-versed in, and I'd love to hear what your insight. And the other is this hot topic right now about the vaping act, vaping sicknesses and deaths that apparently are going on. And I don't know much about that. I'm sure you do. Okay. So that's what we're going to dive into that right away. So
sounds good.
Now we were just before we started, we were talking about Sarah Blythe, who you know, and hello, Sarah, if you're listening to the show. Sarah and I also know each other, and Sarah helps run the safe injection site in downtown East Side. Is that right?
Right. We call them overdose prevention sites because they don't have the same sort of rules that a classic supervised injection site does. But there's in the downtown East Side proper, there's 5 of them now.
Oh, are there?
In the province, there's I think 28.
Okay.
So there's been a proliferation of overdose prevention sites in the province.
Yeah. In your view, are they doing the right thing? Is it working out? Is it good for our society that these sites are popping up, and are they regulated?
Yeah, definitely. I'm very pro harm reduction. I came to Vancouver in 1999, and that was a pretty bad time also for deaths and HIV transmission. And I was the co-lead evaluator of Insight when it opened in 2003. So I've been involved with supervised injection sites for almost 20 years. And we had Insight in Vancouver since 2003, as I say, and nothing else to accompany it until 2016. And now, because of the overdose crisis, a bunch of them have been able to open.
Okay. And on the regulation side, are they regulated? Is there kind of some kind of body that oversees these to ensure that they're
each regional health authority takes some responsibility for them. So they've been allowed to proliferate to suit the clients and the environment that they're in. So there's a sort of a wide range of looks of the different OPSs throughout the province, which is good because one size doesn't fit all for all the communities. So, and even in Sarah's work on Hastings is basically right across the road from Insight, and so they have attracted different types of people who use those two sites.
Okay. Now you mentioned earlier about when you first came to Vancouver in 1999, there was a similar challenge that was being faced along HIV.
Right.
And I understand you actually spent some time dealing with HIV actually in Africa. Is that right?
Yeah, my whole medical career has basically been about HIV. So
really?
I started medical school in 1982, and that was basically the first case of AIDS that was ever reported from San Francisco, New York. And then I was involved initially through my medical training. I was quite interested in infectious diseases and HIV. Mainly, my work in Ontario was about gay men. And then in 1990, I moved to Africa to work with HIV prevention in Nairobi in Kenya. So I was there for almost 5 years. And then my next job was looking at HIV among people who use drugs. So it's basically been my HIV prevention's kind of been my whole career.
Wow.
Yeah.
I didn't realize that. Well, on that topic then, if we can dive into that a little bit more, I grew up, born in 1974. I grew up, around the time in which HIV was becoming a major issue, a major topic. As a young guy, turning my teens and my 20s in the early 90s. And there were obviously lots of people dying from this. I mean, the time at that time, as you know, there was an expectation that without a cure, this was going to become like the biggest killer on the planet.
Yeah.
And then miraculously, it seems like, and I don't know enough about it, it doesn't seem like anybody talks about HIV and AIDS anymore. And my wife, who's got a medical background, she's a dentist by trade, so she's got a little bit more medical background than I do for sure, has said that, most people today, if they do contract HIV, will likely live a fairly long life because of the new medicines that are out. Is that true?
Oh, yeah. No. So, new infections still occur, and there's still, I think 12,000 people in Canada living with HIV. So there's still a lot of people with HIV, but most are on treatment and their viral load is suppressed. There's about 250 new cases of HIV every year in the province of British Columbia. So there's still some transmission, mainly among gay and bisexual men. But again, there's stigma attached to HIV. Clearly, we want to prevent every case we can. But as far as your medical outlook, things are pretty good. So you take a pill a day.
Yeah.
But as far as a global epidemic, it still killed like 20 million people, and there's another 20 million that are infected. So it's a huge,
globally.
Still, globally, yeah. So it's still massive, and though we made great steps in treatment, it's not curable, and people have to remain on treatment, and which means taking pills every day. So,
right.
Or one pill every day, and if you stop taking your pill, HIV comes back. So it's still a chronic disease for people.
And I know this is going to be a silly question, Mark, but what is the difference between HIV and AIDS?
Yeah, it's not really a question anymore. Before there was adequate treatment, there was a list of opportunistic infections that when your immune system got to a certain point, you were more prone to get those. And if you developed one of those opportunistic infections, you were said to have AIDS. We follow now something called CD4, which gives a good measure of your immune status. And so people who keep their CD4 up are very unlikely to get any of these infections. And if you go below a certain point, then technically you sort of have AIDS. But it's really not a useful designation.
Okay, I see. Now, as far as the drugs that have helped sort of suppress this, what is it? A virus? Is it a bacteria? What is it? What is HIV?
Yeah, it's a virus.
It's a virus,
transmitted virus, and there's the antiviral medications that are now available are very specific to the HIV target, and so they have very little other side effects. So they're very specific to the HIV virus.
And is it just one drug company in particular that developed this, or has there been multiple medicines that have come out?
There's multiple medicines. There's different targets. So even though people can generally take one pill, it's a combination of usually 3 different compounds that have different viral targets that work together.
What is it? One of the big drug companies that developed these, or were they small? Do you know the story there?
Yeah, like most breakthrough drugs, it starts off quite small in like university laboratories and stuff, and then it's bought up by pharma companies, and they develop it further and they market it. So, in the whole scheme of things, probably there's 4 or 5 active HIV drug producers in Canada right now.
Yeah.
And depending on the next latest drug, one company could dominate over another for a while, and then kind of bounces around and they buy each other up.
Right.
So,
Mark, do you have a view on that from how that system works? Like, do you have I know if you listen to somebody like, it's hard not to hear him shouting and tweeting, but Donald Trump, of course, has been quite a critic of the cost of pharmacare in the United States, that these drug companies, in his view, charge far too much for their drugs. Their argument, of course, is that there's a lot of money spent on research and development. Do you have a view on the way the system works today? Is it working? Is it broken? Is it problematic?
Well, the fact that good HIV treatment's been available since 1996, which is like 25 years ago, and the price per year of antivirals hasn't changed very much. So it's still between $20,000 and $30,000 a year for somebody to be on antivirals. And
is it really?
Clearly, a lot of people have been some of these drugs have lost their patent, but they've been replaced by newer, slightly improved drugs. So the pharma industry, as far as HIV goes, has managed to keep the drug prices quite high for countries that can afford it. Whereas generic treatment, a year of antiviral treatment in Canada, let's say, is $20,000, and a year of treatment in a place like Africa is about $200.
Is that right?
Hepatitis C is another great example where when the new drugs for hepatitis C were introduced, which are extremely effective, they were $100,000 for a 6 to 12-week course. Canada, I think it's kind of top secret, but I think we're paying between $40,000 and $50,000 for a course. A course of treatment in Egypt is $60.
Wow.
So clearly, there's the manufacturing process isn't what's costing all the money. It's
just it sounds to me like it's just negotiating.
Yeah.
And again, going back to what Donald Trump claims is that actually Bernie Sanders has said this as well. I listened to a podcast with him with Joe Rogan, how he actually took some elderly people that needed some kind of treatment up to Canada to get drugs in Canada because it was cheaper. And they both claim that that's part of the problem is, at least in Canada, we have a universal healthcare system.
Yeah, we don't have a universal pharmacare system, and that's what they're trying to get, right?
Okay.
So that was the big liberal platform this time that we should have a national program because the cost of drugs are up to the provinces to negotiate.
Oh, so it's negotiated at the provincial level.
Yeah. So
the province of Ontario could be paying more or less for the same drug the province of BC is paying.
Yeah.
So it's negotiated at the provincial level.
Yeah. I mean, there's a lot of cahoots across the provinces. So, companies will only go so low for a particular province, I'm sure. So, but it is, it is all negotiated. And once the manufacturing costs of these drugs are not very high. So it's really just, marketing and continuing to ensure profits.
Well, I'm sure if these treatments are, hundreds of dollars versus tens of thousands of dollars in countries like, in some countries in Africa, I'm pretty sure that the pharma companies are not doing that out of goodness of out of their heart. I mean,
no, they're not supplying it at all. So these are all kind of rogue generics.
Oh,
so
I see.
India,
Sorry. Gotcha.
Brazil, different countries have decided to produce their own, and ethically, it just seemed like the right thing to do. But there was huge delays, though. I mean, we had good treatment in Canada starting in 1996, and good treatment arrived in Africa, 2004. There was a huge, huge delay. So the idea was that these countries could not afford treatment.
Yeah.
Which is obviously ethically.
Yeah, it's amazing. Yeah,
yeah, so,
it's amazing. So you have found a cure, or maybe not a cure, but a treatment, but not everybody gets access to it because they don't have the money.
Right. Like whole countries, millions
of people. Yeah. And I guess the pharma side of that argument would be, well, if we were to actually sell this to everybody at the generic prices, we'd close up shop because we wouldn't be able to afford to have all our research development. I'm just trying to say what they would probably say. Is that fair?
Yeah, I'm sure. I mean, maybe we don't want to go down this rabbit hole forever, but I mean, that we know that a large proportion of the profits go to marketing, not research and development.
Right.
And for instance, the Hep C drug was developed on a small scale in a small lab.
Okay.
And Gilead bought that compound for $10 billion. So they didn't invest in the research. They paid for all that research based on the idea that they could, really make a profit on the new compound if they marketed it properly. And they did. In the first, they got their money back within the first 6 months of the Hep C, and then it's just been gravy ever since. So,
wow.
So the companies themselves, I mean, there's obviously research that goes on, but a lot of the real discoveries are made in smaller labs. And pharma companies are more in the market of trying to tweak existing treatments and market them differently.
Yeah.
So as far as breakthrough drugs, I think in my world of infectious diseases, certainly HIV has been in my in my generation, and now more recently hepatitis C is definitely a huge breakthrough. But the other antibiotic parts, things have really lagged behind. And, we could talk forever about antimicrobial resistance and things, and the lack of any promising or not enough promising antibiotics in the pipeline. So the apocalyptic story that, in 10 years, hospitals be filled with untreatable infections. So that's
wow.
That's a concern.
Okay, well, that's definitely a fascinating topic to go back on round 2.
Right.
Okay, well, let's go back because I don't want to go down that rabbit hole. You did come in here to talk with us about drug policy in BC. So maybe let's go back to let's talk about opioids and fentanyl. Obviously, it's a big topic.
Mm-hmm.
There's been a lot of people who've died from this, not just in British Columbia, but globally.
Yeah.
And as I understand it, the supply chain for fentanyl is coming largely from Asia. Is that right?
Well, I think a lot of it's tracked to that, but it's all done by organized cartels for the most part.
Yes.
So,
but you don't need to do fentanyl. It's more of a chemical based. You don't need plants, do you?
No, it's totally a synthetic morphine compound. So it's designed for long acting opioid pain control.
Yeah.
And so it is manufactured with a series of ingredients and chemical compounds and procedures. So both fentanyl and the raw materials around fentanyl have been tracked a lot to China, because they have 100,000 pharma companies in China, and they can pretty much send what they want. So, but I think the focus should not be on where the supply is. Excuse me. The supply is really driven by the demand, and so the whole introduction of fentanyl into the system is directly related to our drug policies and prohibition. So it's as we clamp down on certain drugs, other ones show up. It's so predictable.
Right.
And so, we first noticed an uptick in number of people dying of overdoses about 2014, 2015. And in the province of British Columbia, we keep track of people dying of unintentional overdoses, and it's been 200 or 300 a year for the past decade or so. There was
up until 2014.
Yeah.
Okay.
And then 400, 600 started to go up. And then it seemed to peak in 2017. There was over 1,500 in the province. 2018, another 1,500. This year, the final, it's not the end of the year yet, but it will probably be between 1,000 and 1,200. So it's leveled off from what it was. But nobody would have predicted, 4 or 5 years ago that 12,000 Canadians would die of an overdose, or 4,000 British Columbians. Right. That was not predicted at all, and thought it was just a blip because fentanyl had not been in our drug supply before. And so basically following the both the toxicology of people dying, but also just the drug bus and drug testing that had been done, we went from a city that was pretty flush with heroin to a city with no heroin. So it's all people buying opioids now are buying fentanyl. And at the beginning, people were kind of caught off guard, but anybody buying the street drugs now totally understand and expect they're getting fentanyl. So the whole system's been
incredible.
Changed. Yeah. So
that spike is directly correlated to the sort of uptake of fentanyl.
Yeah, it's all been replaced. Our heroin supply, which heroin is not as potent as fentanyl, and it's more predictable to kind of mix and match it and the potency of it. Fentanyl is so concentrated that it's very difficult to come up with a proper distribution or proper dose, because when you buy a little baggie of powder, it used to be white, but now it comes in all different kinds of colors. A very small proportion of that is fentanyl, and the other fillers and things. So because if you took just straight fentanyl, a little baggie, you wouldn't tolerate that.
Right.
So since it's very very difficult to mix it properly, you get some bad batches hitting the streets. And also because it's so potent, you get people whose tolerance is a bit low for one reason or another, and so they just get a get more than they can handle.
And would this relate to why you hear examples of young people who maybe have never even really done drugs before, or they barely touch drugs? They try fentanyl once, and they're dead.
Yeah, fentanyl would not be your first drug that you want to try. So many people, when OxyContins were readily available, and even heroin, people could usually adjust their dose and not overdose. But somebody that's totally uninitiated, fentanyl would not be the first drug that you'd want to expose yourself to, just because it's so potent.
Sure.
People who have had a lot of experience with opioids build up a tolerance, and the fact the whole drug supply is now fentanyl and not everybody's dying. So there's people out there on the streets today who will take fentanyl 6 or 8 times today, and they won't overdose.
Okay.
It's not the fentanyl doesn't kill people on its own. It's just you have to make sure you take the right amount.
Right.
And so people are not, the stuff they buy is just totally unregulated and unpredictable.
Sure.
And that's why also you see waves of overdoses in the city. So you go from a slow week where, there's a few overdoses to catastrophic weeks or weekends when, 30 people drop. And so it's, a new batch comes on and it's way too potent.
Wow.
So it's, and
Mark, sorry, just for one sec, because this is where you're going to see how ignorant I am around the whole world of street drugs. What is the difference between an opioid and fentanyl? Is an opioid more of a generic parent kind of?
Opioid is just, it captures the whole class. So heroin's an opioid, codeine's an opioid, morphine's an opioid. So they're all, they're euphoric kind of drugs. They treat pain, and they're also respiratory depressants if you take too much. So the whole class is opioids, and fentanyl would be considered a very potent synthetic opioid. You've probably also heard of carfentanil, which is a kind of cousin or analog of fentanyl, and that's also been detected in our system. And again, it's much like other opioids, only it's super concentrated. So a very small amount of carfentanil can easily cause overdoses. And so it's really, again, the mixing of this, if it's done in somebody's basement in their blender, it's really hard to use carfentanil in any kind of controlled fashion.
Right, sure.
But the drug itself is just acts like any other opioids, but you just would not take very much. And carfentanil, for instance, isn't used in medical practice at all. Fentanyl is widely used in hospitals and anesthetics, and it's quite common. The fentanyl patch, which was one of the first times I saw fentanyl on the street, is very common and effective treatment given to people with chronic cancer-related pain. So it's a slow-release fentanyl. You put a patch on your arm. It's programmed it absorbs in a very slow fashion, so you get 24-hour pain relief by plunking on a patch. So it's it's highly effective that way. But people started diverting these patches onto the street and cutting them into strips and boiling them down. And
wow, that's how it started. Huh?
Yeah, but that's what people do with their drugs.
Yeah,
so,
wow, incredible.
Yeah.
So when you look at the leveling off of these deaths, not to sound morbid, but is it just because there's already been so many people have died? There's not as many people taking it. Like there's just a lot of, or what is the reason that you think it's leveled off?
Well, the most vulnerable people have definitely gone.
They're gone.
And there's, sadly, there seems to be an ever-ending train of people. But the people, a lot of people that I have known or were well known on the street have now gone, and it can't last. Most epidemics sort of peak out just because you run out of vulnerable people.
Sure.
There's still a lot of vulnerable people. I think one thing that lost in the statistics is that we have to also look at overdose calls and a number of actual overdoses, because the one thing that we've done relatively well and probably the best we can is reversing overdoses. So obviously, the first responders are much more versed and are ready to respond quickly to overdoses. We have a whole army of community people with naloxone kits on their belts, reversing overdoses all over the place, and their friends. And the overdose prevention sites intervene in a lot of overdoses. So the reversals have gone up, and you can see in areas like the downtown east side where, I think the last I heard it's like 1 in 25 overdoses calls actually die. So there's a lot of responders. In more rural places where there's not as many people around, it can be like 1 in 2 because if nobody's carrying naloxone, there's nobody around.
Carrying a what? Sorry,
naloxone kit.
Okay.
So naloxone is a kind of magic drug that dislodges the compound from your brain receptors, and you wake up. So I've attended a lot of overdoses now. So you go from somebody who's hardly breathing or not breathing at all, and you inject some naloxone, and in a minute they start to shuffle around and start to bat their eyelids, and in some cases dart up, sit up straight. I mean, it really is quite an effective antidote to an overdose. But you have to be there. You have to give it relatively quickly, and even so then, we're still not really measuring very well the damage that occurs from people who are hypoxic for periods of time. So,
what does that word mean?
Like, so that don't have any any air going to their brain. So that you come across. I've seen it myself. People that are really lifeless and blue, and they get naloxone and they sputter back awake. So it's pretty remarkable.
Wow.
But it's not good for you not to have oxygen to your brain for periods of time. And
sure.
There's people in the ICU today, I'm sure, who have, really were revived very late in the game, and they've just had irreparable brain damage.
Yeah.
But there's probably a whole spectrum of brain damage out there that people can still function, but their memory's impaired and concentration's impaired and problems because they've had a brain injury.
Right. Mark, what is the definition of overdose? Like, what would you define that as?
Yeah, that's a pretty interesting question because people who are using opioids are looking for a state where they call it nodding off, or so you want to hit a place where you are pretty sedate, and a lot of people after they inject, you can see them, looking like they're sleeping on the, leaning against a wall or something, and technically they haven't overdosed, and but it's so hard to tell. There was a woman who died a couple of weeks ago right outside the overdose prevention site who people knew she was lying there for quite some time, but figured she was just sleeping it off, and eventually somebody shook her and there was no life there. So,
wow.
And she was dead. So it is people do look for a state many times where they are drowsy, but they're not overdosed. So it is a fine line. Certainly when people go down in, when they're observed in an overdose prevention site, you hear noise because they fell off the chair and they're on the ground and unresponsive. I mean, there's really that's not hard to pick out, but there is a kind of fine line between an overdose and not an overdose. Now, a lot of people who are using these drugs also do not get. You're not really searching for euphoria. They're searching for not feeling sick. So a lot of people do. Go on to the nod and sleep. But there's a lot of people out there who are using regularly who you can't really tell they're functioning, and they just they need the drugs because if they don't get them, they feel very sick.
Wow, fascinating. So when you look at the people that you've seen in downtown Eastside, let me take a view of someone who has ever really been down there. Maybe they see pictures on the news every now and then. Maybe they have the view of like, why don't those people just clean themselves up?
Yeah.
Can you kind of enlighten us in sort of a little bit for those who've never really been down there or seen it? I mean, I have to admit myself going down to go see Sarah. I would talk to a few of these people, and it was quite fascinating because these people are actually, for me, I was kind of surprised. These people are quite normal. I mean, they're quite happy, friendly. You kind of have this vision of these. I mean, at least I had this preconceived view of these people being kind of like zombies and down and out, but they were actually really friendly, happy people. But you could tell they had a real issue or had a problem. You kind of hit a couple of things there. One is
obviously the societal view is people should just stop using drugs and get on with it. How else could we tolerate 4,000 deaths and not really do very much about it?
Yeah.
Or how could we just go through a federal election and it's not really even mentioned that 12,000 Canadians died? Imagine if 12,000 people died in airplane crashes or, Ebola or these kind of things, so it is, there's no doubt about it that the public perception is that people should not be using these drugs. And, if they are silly enough to be using these dangerous drugs, they know they're dangerous and they die, like it's, buyer beware and blame the victim, So there can be no other reasonable explanation to explain our society's lack of attention to this issue. So I think that's a sad statement, but that's...
Do you think it's simply the fact that there's a socioeconomic sort of correlation? I'm making an assumption here, but I'm assuming that most of the people that are in downtown East Side, they didn't grow up in a middle-class family in West Side Vancouver or North Van. They probably...
Well, everybody's got stories. There are people that definitely did.
I'm sure there are. I'm sure you can... But, if you look at it, I don't know the stats. Look, I don't know. I'm just asking you. You have a better idea than me.
No, there's a lot of generational issues. So a lot of times families are no family members and they end up there. The same kind of trauma. Clearly the... First Nations issues in our province. There's a disproportionate number of people with First Nations background who have gone through, unimaginable trauma in their lives, and they find themselves there. So I think it's not maybe so much the socioeconomic status that you start out with, but more the trauma that you have to bear in your life. So, I worked there as a frontline doctor as well as a researcher, and I've talked to, thousands of people as patients, and everybody's got a story. And I guess, pulling one word to describe it would be trauma, whether it's an injury you suffered or a loss of a family member or a violence and abuse that you suffered when you were young. Sexual violence is a huge issue. So a lot of people have reasons that they have, used drugs to numb their pain. So most people down there are numbing their pain with drugs. That's how it started. And then we put them in a situation where it's just more trauma on more trauma. So a lot of people didn't start off in the kind of poverty that they're in right now. But there's people, walking in Vancouver who don't have one penny to their name, basically. Every day's like, how am I going to survive today? And so nobody started out wanting that way, but we put them in a criminalized situation that we just make it worse and worse and worse. And we've tended to try and treat this problem as a criminal justice issue. A very large percentage of people down there have experience with the criminal justice system. And a lot of people in and out of jail all the time, in and out of the police station, and they're picked up all the time. So, we've got ourselves in a situation where we just keep re-traumatizing people over and over and over, and then we expect them to stop using drugs, and they just will not, because that's the only thing. We kind of think of drugs as the problem, but the drugs for people using them, for the most part, are their answers. That's the only thing they have to look forward to in the day is getting their mind off their trauma for a couple hours at a time. So.
That's a fascinating way to look at it. I've never actually had someone explain that to me before. Would you agree that we've made at least some progress in that, in the 80s and 90s, like when I was growing up as a kid, if you were a drug user, forget about the drug dealers and the drug pushers, those were definitely criminals. But if you were a drug user, you were also a criminal. And it seems to me like, at least, I don't know if it's practically happening, but societally, I think people are moving away from the idea that if you're a drug user, you're a criminal. Is that progress at all?
I think that maybe the attitude in the general public has shifted a little bit, but what's happening on the street hasn't changed very much. The numbers of people arrests are not down; they're up. Really? We still have 70% of people in jail. They're on drug in our whole society. Our whole jail system is 70% drugs. So, and most of those are not violent. Most of those are people that they've had to. Many of them have had to.
So what are they getting arrested and charged with? Are they getting for using or for distributing?
Well, it's so much of the drug life is tied up with living on the margins and surviving. If you're getting, you have to pay extortionary prices for the street drugs. There's somewhere you need to find that money, and often it leads to some sort of criminal activity. So, it's even if police say they're not like frisking people and arresting them for possession of drugs, their whole hustle to survive in that environment puts them at high risk of the criminal justice system.
Right, makes sense.
Yeah. Even for loitering, I mean, it's the way we treat people. There's people are trying to sell stuff to get by. That the tragic thing is, there's all these people selling all these goods on the street just to make a few bucks, and we just pick them off one at a time. They come every day, they sweep the streets and take everybody's stuff, and they shove them off. Yeah, the city. I mean, it's all like we have to clean the sidewalks off, and these are the people that are trying to get by without doing something illegal, like blatantly illegal, right?
Yeah, sure.
So they're not holding people up with a knife, and they're trying not even to shoplift at London Drugs. I mean, they're trying to do something else, and they're just such easy targets that we just sweep them away. And so we force people into situations because they're going to need their drugs. And so they're going to do something to get that drug. And the more we push, the more desperate people get. A lot of women turn to the sex trade and the violence associated with that. So we've really created an environment that people can't get out of, and we've just made it worse and worse for people. And so I think, as you started out, that we have made some progress. That people are maybe not criminals just because they're using drugs, but as long as drugs are illegal and criminalized, then we've created a whole underworld for this, and people find it very difficult to break out of.
Yeah. So are you of the view that we should lift prohibition and really just allow these to be regulated, taxed, to kind of move one step further from what we've just done, what's just happened with cannabis? And
I mean, there has to be stepwise. So the people that, and again, the issue of the overdoses, the curtain has been pulled back, that there's a lot of people at risk. So it's not just people living in shopping carts in the downtown east side. So the overdoses are all over the province. It's affected people from different socioeconomic classes, and people kind of in the middle. The young men in the trades have been particularly hit hard with this as far as overdose deaths. So there was a lot of opioid pill use in that population that when we've cut back on the prescriptions, that they've been forced to go to the illegal market. So we've the focus can't just be on the downtown east side necessarily. But if that's the group that I'm working with and most familiar with. So I do think that because of this is really a poisoning epidemic, that people deserve the opportunity to get something that's not poison. Right. I don't think we're ready to jump to this tax, regulate, buy like that. But right now, I just feel that the only really practical solution is to give people access to the drugs they want right now in a regulated fashion. Obviously, the direct impact of that would be there wouldn't be as many overdoses because people could have an alternative to buying mystery drugs and fentanyl. But the other thing we were just talking about is trying to break the hustle. So and we have experience with regulated supply at the Crosstown Clinic, which has been operating for a decade. And there's about 140 people who go there every day for observed injections. And so the biggest benefit to those people is they wake up in the morning needing drugs, and instead of going to a dumpster or going to do some kind of criminal activity, they go to a nice medical clinic and they get their drugs, and their lives are transformed instantly because they don't have to hustle. And so I think that's a key thing. And if we want people to engage with care and get on with their lives, if we can influence the pressure they're under to get their drugs, I think we at least open possibilities up for people.
Sure.
Because I've been, working there as a clinician, you can't really survive if you're based on appointments because people have a different schedule than you. So doctors get extremely frustrated when they first go down there, and they're used to having, a list of 30 patients who come in on regular times, and they sit in the waiting room they have to wait, and they never ask any questions. And so now we're dealing with people who just don't operate like that, not because they have necessarily a job to go to as we define it, but they're really busy because their life depends on it. They have, 4 hours to find some money and get some drugs before they feel sick again. And so the coming to see me as a doctor is not high on their priority list. If they'll come if they score something quickly and they get their drugs, and then maybe they'll have time to come to their appointments or come to their job or if we want to retrain people or whatever kind of help we want to give people, as long as they spend 24/7 hustling after drugs, it's really hard to find time to do that.
Yeah.
And even to have a couple hours just to sit back and look at what's happening to you,
Yeah, sure.
Well,
I think you bring up such an interesting point here, Mark, that I never really considered as someone who's not in this every day like you are, which is just the hustle that these people have to go through every day just to find enough money to be able to get the drugs that they need so that they won't go back to feeling sick. And then on top of that, they have to actually exist. Like they have to eat, they have to sleep, and they got to figure that all out every single day.
Every day is an adventure. And then if you're constantly being pushed by police, the emphasis on tent cities and stuff. I mean, for a lot of people, having a tent in Oppenheimer Park is the most secure place they can be right now.
Right.
And so we spend all our time chasing them out of there. And now where do they go? So, I mean,
it's not like they're going to just go somewhere, it's not like they're going to figure out a solution. It seems to me like the back of the napkin solution here, because from just listening to you talk and my own observation, I've lived here about the same amount of time. You came here in 1999. And while I've been down there every day like you've been, it seems like it's not improved at all. Like it is, every time you go to downtown East Side, you drive through there, you walk around there, it's just the same shit. And it's been going on for my grandfather's 95, he's still alive. And, my grandmother used to work at the bank down there on, was it Hastings, and there used to be 4 banks right in the corners.
Hastings and Maine.
Hastings and Maine. And he said it was bad, back in the 30s and 40s, not obviously like it is today. So I love that, that I don't remember who it was. I think it was Albert Einstein who said the definition of insanity is doing the same thing over and expecting a different result. Yeah. And I like what you're saying. I mean, to me, it seems to simply, back in the napkin solution is, why don't we just give all of these people in the downtown East Side a minimum amount of income every month, guaranteed? Mm-hmm. It's something far better than what is it called when you're on
your welfare?
Yeah, welfare. Sorry. So give them double, triple the welfare, so that they don't have to go hustling or criminal activity or going the sex trade to be able to pay for a sandwich, and then give them, the access to the clean drugs they need. So the ones that want to get off it and can get off it, but the ones that don't, or the transition, at least they know they've got something that is going to be clean. It's not going to put them on the deathbed.
And eventually they will. I mean, the natural history of addiction, if you survive long enough, that you stop.
Right.
Like it's not, that I think we, especially in the medical field, when we label it as a chronic relapsing disease, in some ways it allows people to take a less criminal approach to things, but at the same time, it labels people and locks them into something that's forever. Like I'm ever going to be an addict, and it's not true for a lot of people. If they can move on, and I've said before that that people stop using drugs when they find something better to do than using drugs. I mean, they weigh the pros and cons of things, and many people from day to day, the drugs is their best option right now. Okay. And if they find a better option, they can start dealing with their drug use. So many people are not put in that position. And I've seen a lot of success stories, but for a lot of people, it takes a long time. So I've followed people for 20 years, and they're alive. They're on their HIV meds. They're doing okay, but they have good months and bad months. And then one day, unexpectedly, they'll tell me that they're not using anymore, and they've got a new house, or they just found a new partner, or like I got a dog and now I'm happy. Things that I couldn't have predicted. But I feel that all the time and energy that the support systems in place kept them going, allowed them to get to that position. So it's not the idea that you can just go down there and just with a broom and just tell everybody stop using drugs. Here's methadone, move on. There's no evidence that has worked for anybody.
Yeah.
We just can't turn it off.
Yeah.
The one difference I think in the downtown east side, my tenure, is gentrification. So some of it even looks worse now than it did because we've really squished the downtown east side. So
really,
when I first working there at the clinic, you couldn't go to a coffee shop, right? You had to make sure you brought everything you needed for the day. But now there's like very nice coffee shops, and so there's nice restaurants.
It has been compressed. There's these, still a bit of a mix, but there's a lot. So the gentrification's really kind of just geographically pushed everybody even closer.
It used to be 10, 15 square blocks was the downtown east side. Now it's 5. There's places you don't go. And we've, the enforcement is, for decades, it's kind of ghettoized that area. So things are allowed to happen in downtown east side. They can't happen anywhere else. And if people stray out of that little confine, then they're in trouble, basically. And that's why, the not in my backyard thing. And so services have been traditionally concentrated in downtown east side because nobody else will allow those services and housing. So a lot of it's very, very contracted now in the downtown east side, and people have really nowhere to go. There's been a lot of housing units that have been built down there in the last decade or two, but not nearly keeping up with the demand because the demand just keeps getting higher and higher.
Right. Yeah. Well, Mark, let's to wrap this up and jump quickly to vaping.
Okay.
You're a policymaker. What are kind of some of the most immediate things that you would do? Because as we just, I think, both agreed, largely, what we've been doing hasn't been working. Mm-hmm. You mentioned just a moment ago about, sweeping that streets up, telling these people to just, take their methadone, you said?
Yeah.
And just, get their lives cleaned up isn't clearly working.
Yeah.
So what would you recommend to policymakers today? Yeah. What do we need to do? What are some really tangible, I don't want to talk philosophically. What needs to happen on the street today to take this from where we've been in for the last 20, 30 years to something far better?
Yeah. Well, the one caution is there's no magic bullet to this, right? Sure. We've got here over decades. It's going to take a while to get. So I don't think there's a magic bullet, but I do think the two areas that have risen to the top are decriminalization. So try and get, and I think getting people out of the hustle is the main reason for decriminal to get that would really impact on crime rates if we allowed people access to a safer drug supply. So they're very tied into each other. But I do think the police should back off even more, and resources that we're now using for policing should be piled into social services and a reasonable income for people, and to try to bring people up economically would be really critical. And a lot of money still goes into policing that I think is counterproductive. And the second is a safe supply. So if we look at this from a public health point of view, if there's poisoned romaine lettuce in your grocery store, they tell you don't eat this lettuce. And oh, by the way, here's some other lettuce you can buy instead, and even.
There'd be a total recall, be all over the news.
Exactly. Yeah. So we're in a massive poisoning epidemic that's not giving people diarrhea. It's actually killing people. And I think an only reasonable response is trying to give people an alternative. And so it doesn't mean clearly going after fentanyl and trying to rid the world of fentanyl, or going to China and trying to negotiate with pharmaceutical companies is totally a waste of time. There's no the war on drugs or trying to clamp down on imports is a lost cause. It just makes worse drugs, basically. And so we need to do this by offering people an alternative source of the drugs and slowly get people moved over. And the one project I'm working on now would be to give people hydromorphone pills, which are cheap and they're legal. And many people would crush them up and inject them. But that's what they've been doing for decades. And I think it's, it's a harm reduction policy. It's not safe, but it's much safer. So I'm trying to, give people an opportunity to do that and to break down the barriers. I'm working on a project that would use a dispensing machine based on biometrics that people could enroll in, and they could access these drugs, and we could regulate them. So we know what's in the machine. We can regulate the schedule when people get them and the dose that people get. We could individualize it. They could come in multiple times
a biometric, you put your fingerprint on there or something?
It reads the vein pattern in your palm.
Okay.
So it's pretty advanced biometrics, but it's like foolproof. So we know who's.
Has this ever been tested anywhere before?
Not giving out these drugs, no.
Yeah.
It's
creative.
Biometrics has been there, but there is a lot of apprehension to this idea. So I'm hoping we have the machine now, and I'm just working on it this week, and hope to get a couple people started on it in the next week or two.
Wow.
So you'll probably hear about that because there's a lot of interest in doing it this way and trying to break down the barriers and give people a little of autonomy when they get these drugs. So a safer supply of drugs. And there's other programs that are being developed in the city to allow people that. So I really think that that's our first step right now. It's been 4 years now. Most people are still buying their drugs in back alleys. The drugs have not improved. In fact, they've seemed to have got worse.
Really?
And the quality is terrible. And we just can't, I just feel
we can't leave it up to a
ethically.
bunch of rogue drug makers that are
basically we're telling people, and the medical profession has drawn the line at giving people these drugs. So we give people substitute drugs, methadone and buprenorphine. But and for some people, this has worked great, and we should be giving every opportunity for people to do that. But for those it's not working on, then we need to offer them real drugs and real alternatives. So I think, to me, that's what I'm really committed to the next little while to really focus on getting people a safer supply of drugs.
Okay. Well, that sounds good. It's different. Sounds like you got me convinced. Let's, how are we doing for time here, Ross?
We're at 51 minutes.
Oh, wow. Come by fast. Are you okay to quickly talk about vaping?
Yeah, sure. Yes,
okay.
You can splice it up and stuff. Or,
Oh, for sure. Yeah. Okay. Let's, Mark, let's jump to the world of vaping. Okay. I only found out recently, having to ask my young millennial team what actually is vaping, because I see the pictures of these things. I don't even know. Is it tobacco? Is it cannabis? And we're seeing on TV these various deaths that are occurring in the States. I don't know if there's been any deaths in Canada.
No,
there hasn't been.
No.
Okay, and a bunch of people getting sick. There's something called a popcorn lung. Fill me in on what's going on here in the vaping. Do you have some insight on this?
Well, this is I first got involved in vaping 2 or 3 years ago because of the very population that I was talking about. Maybe 5 years ago, because I was following large groups of people who had HIV. And as a part of research projects, I was working both here in Vancouver and also I was in Ottawa for a while doing this kind of work. And everybody's dying of tobacco-related illnesses. So as this cohort ages from their HIV is fine. They're taking this pill a day, but they're all have chronic obstructive lung disease, and they're getting lung cancers, and everybody's smoking 2 or 3 packs a day. It's just terrible.
Of cigarettes.
And for poor people, especially, they don't buy $15 packs at 7-Eleven. They buy bootleg tobacco. So in downtown East Side, you get a pack of cigarettes for $3. So the taxation doesn't really impact them. They're all imported from China. It's all illegal, but everybody buys.
There's illegal cigarettes.
Yeah,
come into our really.
Yeah, they're everywhere. So it's wow. Depending on who you're dealing with, it's either $2.50 or $3. You get your pack of cigarettes. In Ottawa, it was basically all loose tobacco in bags, and you get $5. You could buy like a baggie of loose tobacco, and you'd buy rolling papers with no filters, and so people were killing themselves with tobacco, and vaping basically is a safe way to deliver nicotine. I mean, so it doesn't contain. So
let's
any
clarify
of the chemicals.
For those listeners who don't even know, like me, a couple of weeks ago. What is vaping? I see these people with like these look like they call them electronic cigarettes, and you see this puff of, I think it's not even smoke. It looks like
It's just vapor. It's mostly
what
water
is vaping?
vapor.
What is it? What tell us what just mechanically what's happening inside of this device.
So it heats up. So it's a liquid that contains nicotine.
Okay.
You heat it up. It's got some glycerol in it to make it to get it aerosolized, and you inhale it in your lungs just like you do with nicotine from a cigarette. The nicotine's absorbed, and you get the same feeling as you would from a cigarette. Only cigarettes have 7,000 chemicals, 40 of which cause cancer. So you take all of those out of the product, and you just give people basically nicotine. Plus, most of them have some flavoring in them. So again, we think benign. It's the same kind of flavoring in our foods and things. People could argue, well, that they're not supposed to be inhaled. Certainly not. I mean, it's not. Again, it's harm reduction. So right. So
you're not a proponent of vaping. You're not asking everybody to go out there and start vaping. You're saying
if you smoke, you should vape.
Right.
Yes.
Yeah. That's the point here. You're not the pro vape guy that says everybody should start vaping. It's more if you're a smoker, stop smoking, start vaping.
Exactly.
And then eventually stop vaping.
Exactly. And the beauty of the electronics and the technology is you can dial down your nicotine. Like people do want to they start off with a high, you can wean yourself off. And I've talked to hundreds of people.
Do that? Yeah.
Hundreds of people. Because the fascinating thing about cigarette smokers is 90% of them want to quit. And so you have a pretty, an audience that's really on side with you here. Yeah. And how can I quit? I just don't seem to be able to quit. Yeah. And so, let's get you the nicotine that you need. Let's get rid of all this toxins in the cigarettes by burning tobacco, which is terrible for you.
Yeah.
And then we can work on weaning you down on the nicotine.
Because there's no weaning down of cigarettes, right?
No. People tried it. Like I used to smoke 2 packs. Now I smoke 1 pack. And last week I only smoked 15 a day. I mean, so people play with everybody's trying to reduce for the most part, but they have a lot of trouble doing it. There's 5 million people in Canada who smoke.
Is it
so
really?
It's
5 million out of 33 million or so?
It's about in BC it's about 12 to 13%, and we have the lowest rates actually. Yeah. So, but in Iqaluit it's like 60%. In Newfoundland, I think it's 25%. I mean, again, there's a lot of overlap with socioeconomic status. So poor people smoke for the most part.
So what about all these young? It seems like vaping's become really hip. It's like we almost got to a point where teenage kids were like, okay, finally not realizing like smoking is not cool.
Yeah. And it hasn't become cool again. So this idea that all of a sudden kids are going to vape and then start buying cigarettes makes no sense. Like,
no, that's not what I'm saying.
No, but that is one of the arguments. Like we're allowing kids who don't smoke, they're taking up vaping, they're getting addicted to nicotine, and now they're going to start smoking. Yeah. There's no evidence that's happening because we have demonized smoking, and youth don't want to be smelly, and there's nothing cool about lighting up a cigarette, right? But there's coolness about vaping.
Yes, that's what I'm talking about. So I've never heard that argument, but let's talk about that for a moment, about the idea that it seems very obvious to me from what you've described that vaping is a far better alternative to smoking cigarettes. But with vaping developing as it has, this company JUUL has been in the press a lot. That I don't know the numbers, but I got to assume there's a ton of teenagers out there who've gone from not doing anything. They weren't smoking cigarettes because of the reasons you've just described, but all of a sudden vaping's pretty cool.
No, so the numbers are startling. So, 25% of kids have tried vaping in the last 6 months, but underneath that, about 5% say they vape 20 out of 30 days. So those kids may be considered that they've become addicted to nicotine. They really need it. So these astronomical numbers are just in keeping with have you drank at a party in the last 6 months? Have you tried cannabis in the last 6 months? So kids try stuff for sure. So vaping is cool, and people hand it around. So I'm sure. And it's I'm not saying this is an okay thing, but it's a predictable thing with youth. But a very small number are regular vapors and will go on to be nicotine addicted. There will be some though. So we have to do what we can to get education out there and to try to limit the access to these products for youth. So I'm totally on side with that. These products were not designed to get new people using nicotine.
Okay.
But we've lost the whole narrative about what about the smokers? Like we've given because the messaging has been so distorted that a lot of people who did transition to vaping are now questioning whether that was a good idea for them, because look at all these illnesses that are happening now. And so there's
for sure.
Yeah.
I mean, if I was a smoker, I'd go back to smoking.
Yeah.
Now, what I've seen on the press,
which is crazy, because vaping has been around for like 10 years. There's 3 million people who have transitioned in the UK from smoking to vaping. There's not one of these cases in the UK. I mean, it's nothing to do with nicotine vaping. And it's come out now, very recently, late in the day, that it seems like that maybe all or 95% of these cases were THC and oils that were put in these THCs. And
to be clear, for the ignorant listeners out there, THC is
cannabis.
Cannabis.
Yeah. So people, and it's fascinating when you look at the map of illnesses across the United States. It wasn't correlated with the number of youth that were vaping. It was correlated with the amount of prohibition around cannabis. So you take states that have a very tight control of cannabis, and kids all of a sudden heard, oh, I can try cannabis through vaping now. And they buy these pods, and they got sick because they couldn't, they had no opportunity to smoke.
California and Colorado didn't have as many problems as like the
Wisconsin and Missouri and these places where first North Dakota, like these places that had the tightest restrictions on cannabis were the ones where you got all these cases happening. I think the big bust they found in somebody's basement of all these contaminated pods was in Wisconsin. And so, I mean, so it never made any sense that.
So a company like JUUL's been an unfortunate recipient of the bad press.
One person has got sick from using a JUUL.
Really?
Yeah. Now they could have got they could have got addicted to nicotine. I think JUUL has to answer for their marketing strategies to youth. So I think that was reckless and bad on their part the way that happened. Now, most of the stuff that's been brought up on their marketing is from 2016, 2017. I mean, recently that hasn't been their strategy, but lifestyle pictures of people using JUUL was part of their campaign. Yeah. And that was very damaging, and that should never have happened. I totally don't support
Should vaping companies like JUUL be held to the same limitations of marketing as tobacco companies in your view?
I don't think so, because we want to incentivize people to switch. So I think taxes should be lower on vaping products, and the advertisements as far as the health benefits should be put out there. I think
isn't the province of BC about to implement some really strict tax regulations on vaping?
Yeah. I'm not supportive of that.
You're not supportive of it.
And banning flavors. So the other misconception is that adults don't need flavors, but that is a huge attraction. 90% of people who have successfully transitioned use flavors. So adults like flavors too. Now, we don't need to have like princess bubble gum and stuff, but we can limit some of that. But people need a range of flavors. So, but the whole vaping industry, including JUUL's, been caught up in this moral panic around all these illnesses and deaths. There's 42
moral
deaths.
Panic. I love that's great.
Yeah. So some moral panic, and everybody's just like, we have to stop this, And the other irony is, well, banning and prohibition doesn't work anyways. So you can make
as we've
all
just
the
spent
laws,
the last hour talking about.
Go to town on banning this. Like, it's just going to lead to more black market unregulated products, right? So
which doesn't get taxed.
Yeah, it doesn't get taxed at all. So I think the products need some taxing, but everything should be less than tobacco, because we want to disincentivize smoking. So we can't, make it just blanket. Well, everything that we do for tobacco has to also fall to e-cigarettes, because we actually want to promote e-cigarettes to people who can't stop their cigarette smoking.
Right. So, is there anything in this proposed BC legislation that you are in favor of?
Well, I think things that certainly advertising to kids and some restrictions on that, I'm all for that. Like I do think that I'm all for regulated products and regulation. I'm totally 100% behind. People who buy these products don't want unregulated. They want to know what they're getting. They want top quality stuff. They don't want.
How's that? It's no different than the drug users that we just spent time talking about.
Why should we want vapors to buy things from criminals in an alley? And there's all kinds of devices that people use for vaping that again aren't regulated. So they some of the ones that have been tested from very cheap Chinese manufacturing have, they contain heavy metals and like we don't want any of that, right? We want like really good quality products for people. So
did anyone from the province of BC before they tabled this legislation call you up and get your advice?
It's very hard to get my voice heard. I'm definitely, I could say up front, I'm definitely on the outside of the public health approach to this. So I'm one of the few people that look at this as a really important harm reduction strategy.
Yeah.
Most public health is focused on youth vaping and nicotine. And to my dismay, have really not included current cigarette smokers in their calculations. So basically, they're telling the 5 million people, look, there's probably a safer thing for you, but we don't really care about you, but we certainly don't want another generation of nicotine users. And that's when
that is the message, isn't it?
Yeah. The battle is set up between big tobacco, which is, has some of these products, against public health
products?
E-cigarette, against public health who are trying to protect us all. And the battle should really be, there's no voice for smokers in there. And I'm trying to get a voice for the advocacy I want to do is behalf of smokers, not on behalf of JUUL or this big tobacco.
Right.
Although big tobacco, the irony to me is that even if it is big tobacco that we all despise, they have a safer product. And so that is the key thing. And so I used an example the other day, but if Ford, who is a massive polluter of our environment, comes up with electric pickup trucks, we think, well, great. They really did a bad job of our environment, but now at least they're trying to something safer. If Coca-Cola, who's causing all this childhood obesity, comes up with sugar-free drinks, we go, oh, well, good, Coke. Thank you very much for doing that for us. And Big Tobacco comes up with a safer product. We go, whoa, wait a minute. We don't want any part of you people are so terrible that we don't care about your product. We just think that your motives are so bad and you have such a terrible track record. We're not interested in your safer product. Well, to the person who's smoking, I think that we should be interested in their safer product.
Yeah, absolutely.
So I don't really care if it's Big Tobacco is behind this. The only way to scale this up in a quick way would be to use Big Tobacco, I guess, because they can switch all their customers.
Well, they've got the resources, they have the capital.
Yeah, and JUUL,
incentive as well.
This is not widely known, but JUUL was not a big tobacco company. It started out just as a vape company. About a year ago, a tobacco company bought 35% of JUUL. And so now they're considered part of big tobacco. But the strategy there was that every pack of Marlboro would have a coupon that you could get JUUL. So the whole idea was to switch smokers over to JUUL. Like, sure, that would be amazing. That would have been a great strategy. And that was what they were trying to do. But now that's all off the table, I think.
Wow.
So.
Well, it makes sense for their perspective because it keeps I guess if you think about it, if I'm a tobacco company, I want to keep my customers alive. I don't want them dying.
You want to keep them alive, and like the oil industry, your products die. The writing's on the wall.
Yeah.
You can't. Tobacco use has been slowly going down in Canada.
Sure.
So I think that, and that's what public health. The message is we're already doing an okay job, but it's such a slow. The reason there's less smokers over time is because they're all dying. And there's not as many new smokers, which is good. Yeah. But that is no way to solve your problem. We should be trying to keep the smokers alive too. And that would mean that there's more smokers and more people using nicotine in Canada or in the next decade or two, but at least they'd be alive.
Yeah.
And,
sure.
And the other, I know you want to shut me up about this, but
no, I do. This is really fascinating. I want to be the counter argument, but I'll let you do this. And because I want to come back. You and I are both dads of young children.
Yeah.
And I guess my counter argument would be, well, what about the parent who's got the teenage kid who wasn't a smoker and now she or he is vaping?
Yeah.
They would say to you, like, Mark, if we just banned this altogether, yes, maybe they'd still try it, but it's the same. You can make the same argument towards, cocaine. It's a lot harder to get when it's banned.
Well, what about cannabis? So way more kids try cannabis than vaping, and it was illegal until totally illegal, not just hard to get. Yeah. Like you can buy it anywhere legally. Yeah. It was a total black market thing. So
although I would make the argument that it's probably even easier to get now. But
yeah, I don't think it's really trickled down to youth. They still are banned
so
from going
really
into
just a matter of
stores.
it's about making sure we limit companies like JUUL and the big tobacco companies from the ways in which they're allowed to market to youth. Basically, don't allow, and then just about parents being responsible parents and educating their kids on the.
And I think truth, right? So truth is what we should be doing, not scare tactics, because youth especially see right through it. So if you tell your kid that if you try, you try marijuana, you're going to go psychotic. Yeah, they'll look at you like no, I'm not. All my friends have done it and they seem fine. So you have to tell them the truth, right? This is not going to kill you. It's not good to use this all the time. And like vaping, I mean, I'd say to my kid, well, you might try it, but I mean, it's very inconvenient. You don't want to get addicted to nicotine, and you shouldn't do it. And just make it less cool. But I think you have to just be honest with people, right? So this scare that parents will bring the articles from the U.S. and say, look at people, this kid died. Do you realize that? Well, they'll look at you and go, well, I've been doing it for a couple of years. All my friends do it. I'm not going to die. It doesn't make any sense. So we create this moral panic about this thing, and the youth see right through it, right? Okay. They don't. Yeah,
they do their research. They're probably more dialed in than we are.
Way more dialed in.
What's a popcorn lung?
So again, there was a case in the Canadian Medical Journal just did this very in-depth article about a case, and they're calling it it's suspicious of popcorn lung. When you read the case, which I have very carefully, it's not. And they have no pathology to back it up. But this came about years ago when there was lung disease cases in some factory workers who were working in a popcorn factory. And they used for flavoring for popcorn, for butter, they used something called diacetyl. And if you inhale it too much, you can get sick, and it's a very severe lung disease that people got. Very few. It was like, you had to mostly very long-term exposure to this thing. Diacetyl has been found in some flavoring. Pretty much all the flavoring now diacetyl has been taken out of it. It was a very small amount, but because of the toxicity of this, they've taken it out of flavors. So most people have never been exposed to diacetyl, which is the popcorn lung, that have used flavors. Not but that this is one
example of where the mainstream media and parents might tell their children,
look what happened.
You're going to get a popcorn lung. Yeah. That's not the truth.
But we don't know this particular person. They don't have any evidence of even the flavors that they were using, or they have no examples of it to say diacetyl. And the diagnosis was based on radiologic findings or MRIs and chest x-rays. And they're not specific. This kind of pattern has been found in some of the cases in the U.S. too that are due to THC. And we know from the story of this person is they did get bootleg. They didn't just buy commercial. So I don't think it's anything. But it does feed into the concern that we don't know what's in these products. And to me, it just means that, okay, we have to regulate things. Like, we shouldn't be guessing where people are getting their stuff from. They should know where they're getting it from. And it should not contain diacetyl, which is way better than trying to ban all flavors and then putting the whole thing underground where there will be all kinds of stuff. Sure. So, so I think this is not an accurate case study of popcorn lung.
Mark, this is an interesting dilemma. We are going to wrap this up, but I just want to finish off by saying this has been a fascinating conversation. I find this to be such a dilemma. I was quite the critic, and I think I still am, of Justin Trudeau's decision to make cannabis legal. I felt like, why do we have to be the first sort of westernized nation to go this route? Let's let somebody else, be the guinea pigs. And then on top of that, I think he took the cheap route by basically saying, well, I'm going to legalize it, but I'll let all the provinces figure it out. It's been a goddamn mess in provinces like Ontario. He's put out a tweet the day after it became legal saying, we've now made it harder for youth to get access to cannabis, which I think is totally not true. And we've made it we've basically gotten rid of the drug dealers and the criminal activity, which I also think is not true. In fact, I think they're probably having a heyday now because there's not enough production of legal quality cannabis. And you using that sort of analogy that he had and kind of falls in line with what you've been suggesting, which is if we put prohibitions on these things, people are going to go find it anyways. And then you're getting tainted, poorly produced, drugs. Mm-hmm. And so I guess the dilemma I see us having in our society is, where do you draw the line? Like if that is true, what he has said, which is by legalizing cannabis, we've made it more difficult for youth to get access to mm-hmm. cannabis, which I really don't believe is true, because the illegal pool of cannabis is still going to be available to them. And now there's also this legal pool. Yeah. And it's also eliminated the drug dealers. They're out of business. They're just going to go to something else. Why not just carry that on into all the other drugs we've talked about? Fentanyl, cocaine, heroin, and just legalize the entire gamut. And every time some creative, rogue scientist comes up with something new, we just legalize that as well. And then we go into a society where all of the stuff is available. It's regulated. I don't know, maybe you have a reason, maybe you believe that, and then maybe you have a good reason for it. But that's the dilemma I think we face. And I struggle with that one as someone who's got young kids. I don't want to have my kids just have legal access to all these things. What are your thoughts?
Well, I just don't really accept the slippery slope kind of thing. And what's going to make cannabis, like I think the way cannabis stood, I don't think the number of users was going to go up that much because of legalization. What's going to make the number of users go up is different formulations. So that's if the companies start putting this in beverages, where you have a choice when you go in the bar, I can have a beer, I can have wine, or I can have some kind of THC drink. Sure. I think that a lot of people who normally would never touch it would. And
because there's probably a huge stigma with smoking.
Exactly. Right? You and I, well, I don't know about you or me, but but the majority of people who wouldn't be seen lining up in a cannabis store and standing out in front of a building smoking a joint. I mean, that's just not. Most people just don't do that. But if there's other ways to get it, I think people. So that would 2.0
when that comes.
That could open up the number of people that are using it. I think, but without that, I think just taking the criminal sanctions away wouldn't have that much of an impact on who was using it. But it certainly would take away the ridiculous criminal sanctions and limitations of people who are caught with marijuana and their criminal records and stuff, which I think was always a crazy thing. So to me, that was a big reason to decriminalize, because it shouldn't be a criminal thing. We should educate people about the use. And same with if you put, heroin dispensing in London drugs tomorrow, I don't think a whole bunch of people will be flocking to London drugs. The same people who are using heroin and opioids now would want to get it because it's a regulated supply, but most people aren't users. They just were educated. I don't really want to use heroin every day, or I would never do that. I'm scared to death. I've seen the very worst that drugs can do to people. I just don't want them, basically. I'm educated. And so
but you are, but the average Canadian doesn't have your experience.
Yeah, but I think people know, we need to tell people what these drugs can do and the downside to it. And I think that is far more effective than, just scare tactics and banning and all this. We need to just be honest with people about what the upside and downside of these drugs. And
so if the government moved from doing this with cannabis to going with, 10 years from now, maybe I'm foreseeing like somebody says, you know what, I'm going to run on the platform that we're going to legalize all drugs. Yeah. You think you'd probably be in favor of that as long as it came along with that. With the regulation and education. And I think we'd be far better off as a society. And I don't think we'd create a big zombie population or anything. I think people are like the biggest example right now is alcohol, where people can become zombies on alcohol. We totally promote it, right? In my lifetime, the acceptance of tobacco or acceptance of alcohol has gone way up. Right? Everybody talks about it. It's incredible to me just to the advertising behind it. I mean, I wish life was like a beer commercial.
Yeah,
don't you?
But listening even to pop radio, where it's just these young people talking about how drunk they got on the weekend. Right. That was kind of taboo to talk that, when I was growing up. So anyways, it's become so normalized, and I think
And your point being that alcohol usage hasn't increased. It's probably just as normal as it was.
No, I think it has increased. No, I think we've gone way too far. I think we haven't given people the true goods. This can be very bad for you, right? And you shouldn't be drinking as much. And I think we've just let that go in public health. So I think that we've gone way too far the other way in alcohol. And the damage that causes compared to these other drugs there's no comparison. So it's pretty hypocritical. I saw a tweet with Jason Kenney, who's like totally anti-drugs, and he's promoting. He just walked out of a private liquor store with a whole
big case. He had a big case of wine. It was wine. Yeah,
it's so hypocritical. It's a drug. You're just you're promoting drugs, and then if somebody's using cocaine or heroin, you want them all in jail. It's just. It's so hypocritical. Yeah. But that's the way nobody bats an eyelash because it's alcohol. So it's fine. Anyways, so I'm totally thinking punishing people for self-medicating for drugs it's terrible for that person, and it's terrible for society. It wastes so much money. It just entrenches people. The people, the recovery part that I was talking about before, that people will eventually recover. But their outlook is pretty bad. If you have an extensive criminal record, your teeth are all missing, your health is in shambles. I mean, it's hard to pick yourself up. And all those very serious impacts aren't anything to do with the drugs. They're to do with the way we treat people who use drugs. And that we just put them in a situation where recovery becomes more and more difficult. Mm-hmm. And I think we can change that.
Well, I know there's been a lot of talk about expunging the criminal records of all the cannabis related, non-violent cannabis related charges or criminalizations that happen. It seems like a reasonable.
And we should do it with heroin and cocaine. Again, we could clear our jails out if we and all that money, all that daily expense of keeping somebody locked up. If we put that to sort of help them get back on their feet, we could actually make a difference. Yeah. We think nothing of continuing to increase our prison budgets and police budgets, and it just goes on and on and on. Yeah. And if even a proportion of that money was taken for social programming and supporting people, giving them a living wage, I mean, we could flip the whole system.
Yeah. Mark, this has been a great conversation. I've kept you here far longer than I planned to, but this has been great. I really appreciate it. Thanks for coming in. We've got Mark Tyndall. You are, again, professor at UBC, and I forgot the titling. Professor of medicine.
Okay.
Thanks, Mark Tyndall. Appreciate you coming on the show today.
My pleasure.
Thank you. Thanks, Mark.
Bye.